This is a useful talk to have as a review. All of you are at least a PGY 5 and above, 4, and you may have been in the forefront of the thoracolumbar spine trauma a couple of years back and actively need a refresher or still actively involved in it. But basically, let's see. I have no disclosures. This is the only slide that's going to be of a wow slide. The rest is all very review and very boring. Most of these were borrowed from my former partner, Charleston Soro, and Steve Ludwig at the University of Baltimore, Maryland. But the thoracolumbar junction is the most commonly injured portion of the spinal column in trauma. 15% of all major thoracolumbar injuries occur per year in the U.S., and at least 5,000 of them have neurological deficits. And the fractures of the true thoracic spine, it's much less common as opposed to those that are in the major thoracolumbar column. Now, 83% of people with true thoracic fractures will have another major injury, and those 75% will have neurological deficits. So why is the thoracolumbar spine injured? We all know that. We're not calling any names, so everybody should just relax and go about your munchies and coffee and just soak this in. It's like you're either call names or you don't, and I'm not a name caller, so just relax. So the T11 to L2 is the transition zone. Thoracic spine is kyphotic, immobile, and you're moving to the more lordotic and mobile lumbar vertebrae with a large vertebrae. So there's quite high energy forces, and you get this fracture dislocation, shear injury. And the most important concept to get down, and we've talked about this in our biomechanics and also in other lectures all through this weekend, is about spine stability. Spine stability, minimizing the energy, and also trying to put this back together after somebody's gone on a high speed, high energy impact. And the realization is that you're trying to restore the anterior and posterior columns, and also trying to decompress the neural elements or stabilize the spine so the neural elements are not compressed, even in the absence of any neurological function. You still want to realign the patient as best as possible, particularly being that the anterior column provides 80% of the axial load in the thoracolumbar junction, and you want the posterior columns to be at least realigned to resist torsion and also shear forces. Let's see. Hold on. Uh-oh. Okay. So the mechanism of injury these days, most are indirect trauma. The loading rate of this is critical to determine the severity of the injury. And you have to remember that the appearance of the radiographic studies is not the same as the moment of injury. I need to know the history. Okay, this may alter what you do if you know that this happened during a mechanical fall and how old the patient is, etc., versus what kind of neurological deficit they have and the impact. And it's all not just medical legal, but also it's also to do planning. A lot of what I'm going to talk about is more of a historical background as to how we arrive with our decision models, and also how independent surgeons, independent attendings, independent institutions will manage thoracolumbar fractures a little different, but there's some normative expectations. So before we talk about management stabilization techniques, we need to know how we talk to each other about it. Classification of fractures. There is no universally agreed upon classification. It differs. If you go across the pond in Europe, they use the AO classification a lot. Here, we've moved from institutions that still use the old three-column injury method to the thoracolumbar injury classification system, and also add personal and also known modifiers. Personal is what your attending says, and known modifiers are what's known and agreed upon. Ideally, if I want a classification system, I want something that's simple. We don't really have that. It includes the vast majority of the injuries. We don't really have that. Reflect the mechanism of injury, maybe, but not all inclusive. It corresponds to the anatomic pathology sometimes. And it helps you determine treatment options sometimes, and also determine prognosis hardly. And it's really hard to figure this out. It started off historically with a 3-column theory where this is sort of the ABC. When you start, you want to know the ABCs, PGY 1, 2. You just want to have this in your head to build up on, knowing that you have the anterior column, the middle column, and then the posterior column, involving the tension band, pedicles, lamina facet, ligamentum flavum, and the spinous processes. Let's see. And then you want to build up on it and say, where do I have a compression fracture? The worst nightmare was calling a attending as a PGY2 and stammering through this, not knowing. He said, what's the percentage of compression of that vertebral body? I call the chief resident right now. Let me talk to him. That's a bad thing to happen to you. That's a bad thing. If it's happened to you before, I sympathize. I can relate. But it basically is a language problem. And it's 3 a.m. in the morning. This person just came off the high-speed chase, totally intoxicated. Everybody in the ED is running around, and then they dump it on you. And then you've got the old lady who's got myelopathy up on the 7th floor, and now you have to deal with it. So knowing and drilling this down your head is very important. Compression fracture, ligament is intact, the canal is intact. You have a stable burst fracture, you have loss of height, there is some canal occlusion, there's angulation, comminution of fragments, but there's no posterior column injury. The patient's near intact, versus you have an unstable burst fracture, patient has a spinal cord injury. Those are simple things that even with all classification system, if you call somebody at 3 a.m., they want to leap to this. You can give them a score, but they want to know this because that changes a whole lot of things for them. And it's easier to get a grip of this quickly. And then you have the ones that they have to make a decision. Is it tonight, tomorrow morning, or later? Flexion distraction injury versus chance fracture. Every time I say chance fractures are getting less common, I end up doing one within the next 2 weeks. So I'm not going to say that. So this is where it involves posterior ligamentous disruption, body fracture. Anybody here not familiar with anything that I've said so far? Okay, good, perfect. So you can also extrapolate this. The injuries get more severe as I go along. Fracture dislocation, we have complete global instability, injury to all 3 columns that I mentioned. There's a high incidence of neurological deficits. And then it became a little bit more sophisticated. By 1994, the AO classification system came. It was based on a 10-year review of over 1,000 cases, consecutive cases in 5 different institutions. It was intended to serve as a comprehensive classification system that could guide treatment. Let's see. It had 3 models where A, B, and C. A was about compression, distraction, rotation. Any program uses the AO classification system in the United States? Okay, good. But none of the attendees are raising their hands. So it's a retrospective study of, as I mentioned, you have the A group where most of them were compression, stable and unstable burst fractures. The B group, these were the anterior and posterior element injury with distraction, particularly in the osteoligamentous complex. And then the C group that had the rotational type injury. And you got permutations of this, and this was an attempt to communicate. You can have up to 53 separate injury patterns. This was comprehensive, but not complex. And just recently, they came about with finally including neurological deficits. Prior to that, in 2005, and this is what's used a lot these days, would be the thoracolumbar injury severity score or classification system, or TLIX. Any programs that use that right now? TLIX, yeah. Good. At 3 a.m., you can bamboozle your attending and say, well, he's got a TLIX score of 5. And then they want to know about, is it a fracture dislocation? So you know where that goes. So literally, it's a scale which includes injury morphology, integrity of the posterior ligamentous complex, whether the patient has neurological deficits, and it's a point system, right? So injury morphology, you select one compression fracture, and also translation, rotation. These are all scores. So this is the injury morphology. And then you have, go back to the posterior ligamentous complex. You give them as intact as 0, suspected or indeterminate, 2. If it's injured, 3. This is all evaluated by multiple modalities. And then you have your neurological point system. If the patient's intact, is 0, nerve root 2, coda equina, cord, conus, incomplete. These have individual numbers. The qualifiers is actually what makes this important. And all discussion as to whether to treat, not to treat, who to treat conservatively, particularly if in the gray zone, is very determinant on the qualifiers, whether these patients have open fractures concomitantly with a sort of a fracture that can be treated conservatively, overlying burns, inability for you to brace that patient, body habitus, or they have a bone disease or any rheumatological disease that prevent you from adequately bracing them safely. Okay, if they have multiple rib fractures, they may be unstable. We've talked about rib providing support in several of our talks. So, and if they have severe closed head injury, you might want to say, is this a good time for me to do screws, or wait till we know where they're going cranially? And of course, their general health. If I have a 94-year-old with a horrible fracture and they're demented, nursing home, I'm a little hesitant to jump in and say, let's go straighten them out or brace them, because this might be the end of life opportunity. So here are some treatment if you have 3 points or less, by the point system says non-operative. If you have 4 points, that's where a lot of your qualifiers come in, a lot of your decision-making opportunities come in. It's a non-operative versus operative. And 5 points or more, these sort of lead your hand towards you might want to consider surgery unless some other qualifier tells you otherwise. So in assessing this and giving these scores, we try first by identifying the fracture morphology, your assess points, neurological status, assess points, and then you also consider these qualifiers and as such. So an example would be a 35-year-old male fell from the ladder. He's neuro intact. He's got a burst fracture. We assigned 2 points, neurologically intact, 0 points. The ligamentous complex, 0 points, total score, 2 points, non-operative treatment, brace him. I like this. It's great, but there's always some qualifiers that I have to address. What kind of person is he? Is he schizophrenic? How am I going to follow this patient up, okay? Versus a 38-year-old MVA belted driver, complete paraplegia. His score is a 7. He needs an operative stabilization. So this has been validated. 2006 was validated, and beyond that, let's see. Really, what it boils down to is your institution, wherever you end up, everybody has to agree on a classification scheme, and everybody needs to have a buy-in to that and use it. No classification is perfect. The surgical approach may be based on other factors such as your surgeon's preference and also the patient-related issues. My worst outcome was bracing a quote-unquote functionally independent schizophrenic patient who was then found 2 weeks later non-compliant with the brace in his own feces with a complete spinal cord injury. And everybody was saying, well, but the TLIC score said it was a 3. Well, of course, how would you know? It's more like, if you have this situation, it's not a 6-week follow-up. It's a, let me see you in 2 weeks. If you're not there, let's go find somebody for you. So it's intensive. If you brace somebody, if you operate on somebody, they're coming in for a room check or they disappear. But at least you know that if they don't have a PCP, somebody else is going to be dealing with the staples if they choose not to come and see you or follow up with you. But it's out there. If you treat somebody conservatively, you're sort of put out there to make sure that they follow up with you and you can address whatever decline they're having. Again, as I mentioned, in 2013, the AO classification came about again with neurological status and also key modifiers. But I don't delve into that because I'm still trying to see how many groups, other than Dr. Anderson's group and Dr. Chapman's group can use the AO classification. So I think we have to have more publicity about it. It does help, but the TLX, I feel, with their modifiers is adequate enough and addresses a lot of things. Treatment goals, no matter what classification system you use, is you're trying to prevent further neurological deterioration, and you're promoting neurological recovery. You're stabilizing the spine. You're trying to do that by also restoring anatomical alignment, and you're trying to achieve early mobilization and minimize their pain and chronic or possible deformity. So stabilization techniques based on injury options. You have compression fractures, brace or no brace for the majority, and some of them in the subacute stage may benefit from a vertebroplasty or kyphoplasty. You also have people who have a stable burst fracture who may benefit from a brace too. Surgery, usually posterior or multi-level, if they have multi-level bursts, it maybe looks stable, but if it's multi-level, you have to worry about it being unstable, particularly when you're upright. These days, even with bracing, we're cutting the pie really thin. In Canada, they're not bracing some burst fractures. They're trying to see if people can mobilize, they have minimal pain, they can be allowed to mobilize. It all depends on patient compliance and your ability to assess the patient being compliant with a brace. Unstable burst fractures, surgeries for the majority now. And of course, chance fractures, surgery is for the majority. Ideally, these days, a lot of percutaneous fixation techniques are in play, and we did a lot in the lab. I think it's appropriate to do that these days if you can. But like I always say, in a trauma situation with or without a complete injury, you want early, fast surgery. If you can do this adequately and fast enough in an open type situation, I prefer that versus spending 12 hours still after 7 cases doing a percutaneous, taking 12 hours. Not safe, not good. You have to get your learning in quickly and not practice in the patient. So use the opportunities here to do it, particularly if your institution doesn't offer you some of the surgical techniques you're exposed to here. So flexion distraction injuries, I'm moving on with a higher level of energy injuries. Flexion distraction injuries, you may definitely surgery. Sometimes you have to do 360 versus fracture dislocation. Again, you want to do posterior surgeries for complete injuries. Incomplete injuries, you may have to decompress the neural elements anteriorly too. However, like I always say, non-operative treatment does not always equal conservative treatment. And depending on who they are, there's only a certain amount of immobilization that they can tolerate. My 86-year-old may not do well being braced. I may actually increase their chance of a hip fracture, other fractures by immobilizing them. So if you're going to immobilize somebody, if you're going to pursue non-operative treatment, I highly implore you, no matter what your institution is doing right now, to say frequent clinic visits, close observation is required. They have to come and see you. They have to follow up with the trauma service if that's your algorithm in your place. Typically, if somebody's morbidly obese and they have significant neurological injury and they have posterior ligamentous disruption, I get a little bit tense discussing conservative treatment with them. So there are some surgical results in thoracolumbar burst fractures that you need to know. There's a tendency for less kyphosis and better pain and function outcome with anterior surgery. And that's in your hands and also your comfort zone in doing this, okay? You can also reduce the degenerative changes that result from saving motion segments with anterior procedures, but that's not been proven thus far. It just sounds appropriate, but between posterior and anterior surgery, there's only been review and case series showing a good difference, okay? Now, if a patient has more instability or deformity or poor bone quality, I don't advocate short segment posterior instrumentation. You need more points of fixation, and you may need anterior column support. Now, injuries that tend to frighten me include those who have fractures where they have concomitant rheumatologic disorders. People who have a rheumatoid arthritis, ankylosing spondylitis, diffuse idiopathic skeletal hyperostosis, and also people who are severely malnourished. I worry about not treating them aggressively. Long construct, stabilizing them, quick surgery, always a quick, efficient, expeditious approach to trauma. It's always the best practice, to be honest. These are a few cases that I may just skip because we're all almost out of training, and we've seen enough of these on morning M&Ms and being beaten up. So I'll save it for the lab. You have to literally have an opportunity to practice, and I say go out of your comfort zone. At the end of the lab, it's an opportunity to dash out for the beers, but go out of your comfort zone. Do a wide dissection of what you did, just to get a better 3D understanding of putting all these things together. So let's see. This was a final case by Rod Oskewen and Chris Shaffrey. And the person who did the critical portion of the case, which was the closure, was me. And unfortunately, I didn't make the photo op. So this can happen to you. But that's what happens when you're a junior resident. They call you after they've done the photo op to close the case. But I just wanted to say that this is what we used to do. It came in, and these days we're doing minimal access, right? Those days it was like a shark bite. The access surgeon come and dissect laterally, and they'll put the small short segment in for this young person who had this single level burst fracture. And at this point, we're now in Pittsburgh and beyond. They've extrapolated their disc surgery to now applying this to patients with thoracolumbar injuries. And you can see the same techniques, expandable cage technology, and minimal, less than 3-inch incision for same pathology, less than 10 years ago, shock bite, pleural, chest tubes, drain, drop in lungs to now this. So there's been improvements, and you guys are at the forefront of it. You're in a situation where in your institution, when I was a resident, there wasn't not every neurosurgical institution or even an orthopedic institution had the ability to even put pedicle screws. There are some residents, I'll go to courses and they're in PGY 6 and they've barely put in any pedicle screws, certainly never any thoracic pedicle screws, maybe L4 to S1, took them 10 hours to do. And so things have changed. You guys are at the forefront of it. The learning has evolved. The instrumentation has evolved. There's at least a generation change between the last 10 years. And I want you guys to take advantage of it. And this is a huge difference between this patient going home soon, mobilized early. The next patient, yes, should be the prior patient that I closed can be mobilized early, but they're going to be a pain, literally, to get out of bed based on all the other incisional pain and also access that we did. The main issue that you have to consider, no matter the classification system or the pathology of injury, is, are we bracing this patient? Are we going to offer surgery? With the neurological intact patient with less than 40% height loss, who's compliant, there's a huge education, and it's not just formal education, but the ability for that person to learn, their mental status, and if they have any other mental disorders, age, other factors such as body habitus, and the circumstance of the accident. Was it a poor decision one time, or was it a chronic person who doesn't make good decisions? Bracing may cost you. You have to decide, who am I bracing? It's more important than going by your TLIC score, because at that point, if they have less than 10 degrees kyphosis on upright imaging and they meet criteria, and it may seem judgmental and, oh, why don't we have a score? Because we're dealing with human beings and we make bad mistakes and choices. So that's your job as a doctor, as those say, to sort it out. So the level of evidence for surgery is improving. Justin Shear, who is with the ISSG and in Northwestern, they looked at a whole series of surgical cases looking for the level of evidence for what we do. And it showed that in the literature that there's a high level of evidence to support the operative management of traumatic thoracolumbar burst fractures, but the highest difficulty was deciding who needs surgery when you're neurologically intact. And that's something that it's hard for me to give you exact pearls It comes with practice. It comes with paying attention. However, the instrumentation, the techniques, and technical consideration has changed, has evolved. It's better. There's now percutaneous access. I think it's an ideal thing to do for patients with fractures that don't require stripping of muscles. It can look daunting, but it's maybe potentially longer OR times, learning curve. But you have to get over the loss of tactile feel and the visual anatomy. It's very rewarding for the patient, particularly after they've had a trauma. And the MIS thoracolumbar trauma indications are many. There's going to be lots of talk about the principles are the same for almost every application for percutaneous access. And you can use it for almost everything now: thoracolumbar burst fractures, flexion distraction injuries, extension distraction injuries, and fracture dislocations. You want to start with the less, I wouldn't want to start with a fracture dislocation if I've never done perc screws. I want to make sure I can stabilize the spine and then move on. If you talk to Dr. Anand and et cetera, who do this exclusively, the techniques and pearls are beyond the scope of me exposing to you that you can do this. There's definitely a difference between doing this with somebody with a fracture dislocation versus a burst fracture where you have some element of stability. So I do want to implore you to take advantage of the lab, take advantage of the faculty, particularly if you have a particular interest in a modality for treating patients. And really, it's all about learning a uniform language for the mechanism of injury, and also discussing what kind of surgery you're going to do for a neurologically intact patient to keep them neurologically intact, because the non-neurological, if patients have a neurological deficit, that's easy to decide. And always invest in your trauma service, because they will be a bane of your existence. Thank you.